pre-existing conditions something we need to cover in our health insurance plans, solving the worries of those troubled with expensive health conditions? Or is there another way we can handle this population outside of insurance? One that will help keep that system solvent? Our experts today debate this important and timely issue as we discuss how to tackle this problem in today's edition of Debating Health.
Don't you know I'm going fast?
Welcome to this edition of Debating Health. I'm your host, Scott Ehrlich. When Congress was coming up with bills to replace the ACA, the controversy focused mostly on how to replace those people with pre-existing conditions. Those who are already sick and under the old system would have had to pay more for insurance plans if they were able to get insurance at all. As someone who has been taking medication for anxiety for over a decade, I am personally familiar with this firsthand, having been denied coverage under a policy before getting approved under a different policy, albeit at a slightly higher rate subsequently. This was all pre-ACA, of course. Now, having since been diagnosed with type 2 diabetes, it's quite possible that without some sort of guaranteed issue provision, I would be completely uninsurable in the individual market. And without some sort of community rating, I'd certainly have to pay more than a healthy person. So I certainly understand the plight of people with pre-existing conditions. Yet I also understand that I have medications that I have to take and pay for, more doctor's visits that I have to pay for, more lab work that costs money, and a much higher risk of expensive complications than I did before these diagnoses, making these fixed costs that insurance companies know that they will take on if they insure me, coming close to the premiums that I pay them. If I had more significant disease or more complications from these diseases, the guaranteed issue and community rating make me a guaranteed financial loss for insurers, even if I don't get another illness. If there's enough people like me in a risk pool, an insurer would be selling their product at a guaranteed loss in that area. And that's something that no product or service really can stomach for very long. That way, if no healthy people sign up because the prices become so high because of people like me, it really eliminates insurance for everyone. So while it's important that we do something with people like me and people more severely afflicted than me, is putting them in the regular insurance pool at the same rate as everyone else the best way to do it? Or are there better ways to take care of people with pre-existing conditions without ruining the insurance pool for everyone? Our experts discuss.
Hit me with your best shot. Come on, hit me with your best shot.
Our first guest is Dr. Charles Blahous, who thinks we can find a better way to manage those with pre-existing conditions. Dr. Charles Blahous holds the J. Fish and Lillian F. Smith Chair at the Mercatus Center and is a research fellow at the Hoover Institution. Dr. Blahous, thanks for joining us here today.
Thanks for having me.
So I just want to get into some questions. This conversation's based kind of on an article you wrote a while ago on pre-existing conditions, which I know has been a big controversial issue as the House and Senate try to come up with a new bill. Has been a controversial issue in Obamacare. First of all, can you define for our audience what pre-existing conditions really mean and how you might define them versus how an insurance company may define them or how people at large may define them?
Well, that's actually a great place to start because I think talking about those definitions can help us better introduce the policy conversation about what we should do to finance healthcare for people with pre-existing conditions. But I think the loose way of defining them is that a pre-existing condition is any health condition that you have before you join an insurance plan, and generally a health condition that has substantial costs that an insurer would have to budget for financing. And that's important to understand because normally what insurance is for is to help you hedge your risk. It basically enables you to sort of pay a little bit each month to protect yourself from the risk that you might have a costly problem in the future. Normally, insurance is not there to help you pay for a certain cost that you already have. So, for example, you don't wait until after you have a car accident to buy auto insurance. Sure. You buy auto insurance to protect yourself against the likelihood you may be unlucky and have a car accident. But if you already have a certain cost arising from a car accident, what you need is something else. It's not really insurance, but you need help financing the results of that car accident. And so that's an important distinction to bear in mind because a pre-existing condition is basically a known health condition that you have before you join an insurance plan, and it's something that poses substantial cost to any insurer who's going to help you finance the cost of the care.
So for people with pre-existing conditions, really, what can we do about that then? If you're saying they shouldn't be covered through insurance, what really can we do about these people?
Well, that's the big, broad conversation we've been having on a national scale. And I'll give you my somewhat disconnected thoughts as to how I would answer that. I mean, first of all, again, I think it's very important to return to the point that what folks are looking for here is not insurance per se. They're looking for help providing care and financial support to people who have these certain health costs. Now, in theory, there is a very wide range of ways we could go about it, some of which would, frankly, offend our ethical and moral sensibilities, at least to the extent that I've been able to judge them based on all the conversations that I've had.
Sure.
But in theory, you could just say, well, tough. Well, we'll just leave these people to suffer, right? And they can bankrupt themselves trying to pay for their own health care and then be denied health care at the point where they run out of money. You don't really talk to many people who think that's what we should do. And so there does seem to be a societal consensus that we should provide financial support to people who have pre-existing conditions. A variant of that idea is that we would perhaps provide financial support for people who are poor and can't afford to pay for these conditions, but maybe not provide that sort of help for people who are of high income. So you're probably familiar with the Jimmy Kimmel story that was on the air several weeks ago.
Sure.
And there's different ways that people could react to that. I mean, he was on the air talking about the health challenges of his child. And you could come away from that story with a couple of different opinions. One would be, well, no family should have to bear the costs of paying for this unavoidable, unexpected health need of their child. Or you could come away saying, well, Jimmy Kimmel has a lot of money. We'll let him pay for his child's care. But if someone is unable to afford it, we should step in and help them. Now, I will say, again, having talked to a lot of people about this, I think people are still uncomfortable even with letting Jimmy Kimmel pay for all of it, honestly, because people seem very shaken by the idea that rich or poor, any of us could be wiped out at any time by an unexpected health problem. And people seem, I think, morally uncomfortable, ethically uncomfortable with the idea that if you're unlucky enough to have a big health condition, an expensive health condition, that basically we'll wait to the point where you're wiped out financially, and only then will we step in to help you. There does seem to be a societal consensus that there should be a level of financial protection afforded to everyone, so that these expensive health conditions don't wipe them out. Now, and that really brings us to two families of options, which are sort of at the core of the national debate. One is the approach that the Affordable Care Act took, and that is to basically say, we're going to take care of people with pre-existing conditions through the health insurance system, and we're going to do it basically by requiring everybody else to overpay for the value of their own health insurance.
Sure.
Now, defenders of this approach will often say, well, this is how insurance always works. Some people subsidize other people, but it's important to bear in mind this is not really how insurance usually works. Usually the way insurance works is that the insurer assesses the risk that you are going to pose a cost to the system, that you're going to need a payout, and they charge you a premium based on their assessment of that risk. And you buy the insurance based on your assessment of whether the premium you're paying is justified based on the likelihood you're going to need the payout. That's not what happened under the Affordable Care Act. Under the Affordable Care Act, what happened was something different. We said that basically some people are absolutely certain to get a lot more in health services provided than they would be asked to pay for, whereas everyone else would basically have to overpay far beyond the value of anything they expect to receive from their health insurance. Now, that is a defensible choice. We can make that moral choice, right? And I think if we make it with our eyes open, you could say to people, this is part of the cost of being a compassionate society. You're going to pay these costs because we think it's the right thing to do. The problem was that...
So in essence, you're talking about basically it's almost charitable prepaid health care instead of really insurance at that point.
Exactly. And you're saying, you'd be saying to people, look, we want you to buy into this value judgment. We're going to make you pay a lot more than your insurance is actually worth to you to take care of somebody else, right? And that's a defensible judgment. The problem, I think, with the Affordable Care Act is that was not really owned up to, right? Elected officials basically said, oh, well, we're going to take care of all these people with pre-existing conditions. We're also going to bring down your health care costs, and you're going to get to keep the plan that you already have if you like it, et cetera, et cetera. And so that choice was not really spelled out for people, and they didn't buy into it. And then when they found out that all these other wonderful things weren't happening, they got angry. Why are my insurance costs going up? They said they were going to go down. I think had it been explained to people and had people bought into it, maybe you could have sold that approach. But instead, it was really misportrayed. People were misled about it, and I think that well has really been poisoned, and because of that. Which brings you to the other approach, which is that you can just make a direct societal judgment as to whether we're going to have taxpayer-provided support for people with these health costs. You could set up what were called high-risk pools that states would run and the federal government would join in partially funding that would provide care to people who have high health costs. And that last approach seems to be the way that lawmakers seem to be leaning right now. Now, the criticism of that approach is that the funding source might be uncertain, and lawmakers may not be willing to adequately fund or budget for the level of care that these folks need. And that's the criticism. This approach has upsides, too, though, and I think among the upsides are the transparency. You're making a deliberate, willful societal value judgment as to how much support we're going to provide for people with these needs. In my judgment, that sort of transparency is better than the opacity that we had with something like the Affordable Care Act, where basically the costs are kind of hidden in the insurance system. People don't know how much they're paying or why, and they wind up resenting it because there's not a transparency, there's not an open value judgment or moral judgment made as to how much people are paying. If we put it out there as a line item, at least we can have a societal discussion about how much support we're willing to give, rather than sort of trying to hide the costs from the people who are paying for it, which inevitably leads to them, having a certain resentment and frustration over the costs they're being required to bear.
Sure. So you touched on an awful lot there, and I kind of want to start towards the beginning, kind of breaking down some of what you said. First, we kind of got into the Jimmy Kimmel case, and we talked about his child being born with a heart defect. My wife used to work in a children's hospital in the heart center. I know, obviously, once you're dealing with a heart problem as an infant or earlier, I mean, that's a lifelong condition. That's not something where they just kind of patch you up and you're good to go there. But that's kind of one range, that some of these advanced or rare cancers. Someone like myself, for example, I have diabetes. I'm probably 99% responsible for giving myself diabetes due to my lifestyle and my diet. Someone like Mick Mulvaney, I know, said that people like that should not be covered in pre-existing conditions. Should someone like myself be equated and I guess thrown into the same pool as someone that kind of was, as an infant, had no say or just kind of was stuck with a pre-existing condition? Are those really the same things and the same kind of things as far as insurance companies are concerned?
Well, I can give you my opinion about that. It's just an opinion, and it need not be yours or any of your listeners, but I'm happy to give you mine. My own view is that while there certainly are differences in the level of responsibility people have towards their own health outcomes, the problem is that it's so difficult to disentangle that I think you start going into a black hole if you try to do it, right? Sure. I mean, suppose you have two twins, and they're in a family that has a history of health problems. And one of the twins is fit and exercises and eats well, etc., and the other one doesn't eat well, doesn't exercise, becomes obese or what have you, and the two of them both have heart attacks. What do you say about that? Is it certain that the second twin had the heart attack because they were obese? It's actually not, right? Healthy, fit people have heart attacks too. Sure. It's really impossible to disentangle causation here, and I think we probably overstate our certainty about causes from a medical science perspective when we start saying that someone engaged in a behavior that caused their health problem. The most we can say is that someone engaged in behavior that increased their risk of a health problem. Sure. But that's very different from causation, right? There are people who smoke all their lives and don't get lung cancer or don't get emphysema. And so we have to stop short of saying that the person who did get it and smoked got it because they smoked, because we really don't know. My view is that the better way to handle that sort of thing is to deal with it on the front end. If we want to give people a financial break on the front end and charge them less for their health insurance because they eat well or within a certain range of behaviors or have a gym membership and all that, I'm for that. But I really think we go down the rabbit hole if we try to disentangle exactly whether someone caused their own health problem, because I just don't think it's really possible to know that most of the time.
Yeah, it's also, I'm sure it gives you a problem as to where do you draw that line as to what is pre-existing and your own fault versus what pre-existing not. Is it a gradual transition? Is it a fine line? I mean, anytime you do policy like this, and you certainly know better than I do, you always have to draw a line between one behavior and another behavior, as that's where it ends. And I guess it's very hard to decide this should be considered a legit pre-existing condition, this should not be considered a legit pre-existing condition.
Yeah, and if you've been working in government as long as I have, you would be very skeptical of government's ability to do that well. I mean, it's just, the bottom line is you might be a person that has bad genes and also bad behaviors, and you don't know which is the one that caused your health problem. And I certainly would not trust the government to make that call in any sort of objective way. It's just not equipped to do that.
Sure. So the second thing I want to get into is kind of the funding, the pool mechanisms for this, because there's actually a few different ways that have been discussed. I know you got into ACA and how that kind of pools the pre-existing condition risk with everyone else. You got into the high-risk pools. But I know also in attempts to keep continuous coverage, because obviously that matters as well. It's very different for someone like myself. For example, I was diagnosed with diabetes a year ago. If I had insurance beforehand, then I consider that to be legitimate because I got it, I was already insured, versus insuring myself after I already know I have the condition, and therefore the risk becomes certain. So I know in the House bill, they had proposed a cost increase. I believe it was 30% for a certain amount of time for people that don't keep continuous coverage. In the Senate bill, I believe they're discussing a 6-month moratorium on allowing someone to get insurance if they don't keep continuous coverage. Even in ACA, I mean, if they actually enforce the open enrollment periods as they are, that's also meant as a way to keep people continuously covered, because if you get sick in January and open enrollment's not till October and you have to go uninsured till that time, that could also have health impact. Is there a method that you prefer or think is better to keep continuous coverage and or would relate to better health outcomes, or having people keep insurance in a better fashion?
Yeah, I mean, it's tough. I mean, I think I would characterize my attitude as saying I'm sympathetic to lawmakers' current efforts to make it based on a continuous coverage requirement. I'm very modest with respect to my assessment of whether the mechanisms they have in place to incentivize continuous coverage are adequate to the task. That's a very difficult thing to estimate, and smarter people than me disagree.
Yeah, I'm talking. I guess more philosophically. I mean, we could debate all day whether it's 30% or 50% or 20% or 6 months or 3 months, 9 months, or open enrollment should be 2 months. I'm just curious if you think one of these certain techniques is better than the others, or if there's a different one that you think would help inspire people to get coverage before they get a pre-existing condition versus wait till they have it. I guess.
Yeah, and philosophically, I'm very comfortable with the continuous coverage requirement approach. I mean, if you go back to what we were saying before about what exactly a pre-existing condition is and why it's so difficult, if you have a pre-existing condition and you're trying to join a plan for the first time, either because you didn't have coverage at all or you're trying to switch plans, in the pre-ACA world, you definitely had a problem, right? I mean, insurers, before they were required to do a guaranteed issue, which is the requirement to offer you coverage, or community rating, which is the requirement that they not take into account your health history when pricing your insurance. One of two things was going to happen to you if you tried to buy insurance in the non-group market, in the individual market. Either you were going to get assessed and this is if you were lucky, you were going to get assessed a very, very high premium by putting into a high risk category, or you were just going to be denied coverage altogether. They'd say your condition is so expensive we just can't insure you, and you'd be lumped into the category of the uninsurable.
It's interesting just getting into because I actually faced both of those situations for a very minor condition. I had anxiety issues, and I've been on medication for that for about 15 years, which is obvious. That's why I host my own radio show. But it's something where my condition was treated with $10 a month generic drugs. that I've been taking for 15 years with no problems, and I never really had any problems that were, it's not like I was facing hospitalization or anything, but I was outright denied coverage for this in one area, and it's just a fairly reasonable premium for another one. But it still amazed me to see that even a very minor issue like that's something I would have been happy to pay for out of pocket, resulted in a complete denial of coverage for me pre-ACA.
Well, yeah, exactly, and I think people on various sides of this healthcare debate have recognized that the individual non-group market was just not functioning very well. I mean, especially for people with pre-existing conditions. Now, if you had been lucky enough so that you could be part of an employer plan, that's where people with pre-existing conditions were faring the best, right?
Sure.
Their costs could be absorbed in the overall
Sure.
cost of the plan, and this is what led to the phenomenon of job lock, right? People
Sure.
couldn't change jobs. They couldn't afford to change jobs because they might have to reapply for a non-group plan, an individual plan with this pre-existing condition, and it led to people being unable to go where their employment prospects would otherwise lead them. And so this gets around to your question about continuous coverage. I think the key is that we don't want people to be socked just for having to switch from one plan to another.
Sure.
That as long as they have maintained coverage of some way, shape, or form, there should be some level of protection so that they can change their employment and not lose their economic livelihood as a result of doing so. So I think I have basic sympathy with the continuous coverage approach because I think it deals with the fundamental problem we have where people who have pre-existing conditions do their level best to maintain coverage, but are blocked from switching employment or switching plans because of that condition, and that's something that shouldn't happen.
What about maybe just thinking out loud, some kind of buffering coverage, something to say you have to keep continuous, a lapse no longer than say 3 months rather than continuous coverage to allow people to switch jobs and switch insurance or deal with. I know I've talked to people that said, I had a check that was lost and I canceled my coverage and I was able to get it sorted out, but obviously that hindered my continuous coverage requirements there. I mean, just thinking out loud of ways that we may be able to encourage continuous coverage but still give insurance companies some latitude in denying people that are purely just doing it after as a way to subvert cost.
Yeah, well, you're actually anticipating a debate that's actually taking place right now among lawmakers as people have done different versions of the legislation that has been moving through Congress. Some of the retooling of the legislation has to do with exactly that issue, which is allowing for a grace period and figuring out what happens during the grace period. And people have kicked around things like 3 months, 6 months for the extent of that grace period. But that's definitely a respect in which your thinking is tracking with lawmakers.
So the last thing I want to get into is the high-risk pools, and I know that's been a very controversial area as well because of what you said, the underfunding. I know there's been a tradition where people said states have underfunded it. I've written a paper on this and I've tried to track what the actual real cost of people in these high-risk pools are. I looked at the high-risk pools that were contained in the ACA, and based on my analysis of how many people, this was based on the House bill, I haven't really done it on the Senate bill, but based on my estimate of how many people would really face loss of insurance or potential loss of insurance, and that was throwing in a lot of politics and everything like that. But I looked at it as a cost of about $10 billion a year would have to go to these high-risk pools, and my estimate was much lower than what you see on a lot of these mainstream markets. But still, staggering number of things. I mean, that's appropriating $100 billion would only cover you for a decade, and that's assuming my low number of about 1 million people needed these high-risk pools. A lot of other people have pegged a lot higher. So if these high-risk pools are done, wouldn't we still require just a staggering amount of money to cover insurance, or is there another way that we could do it to well fund these high-risk pools but still allow people to escape bankruptcy and receive coverage?
Well, I think the short answer is it's going to cost a lot of money no matter what, right? And we're either going to see it or we're not going to see it, and we're either going to account for it or we're not going to account for it. And the only alternative is that we we don't provide the support. And so I think the basic answer to your question is yes, it's going to cost a lot of money, but not funding it through high-risk pools does not make the cost go away. I mean, Basically right now people are paying for it through their insurance premiums. They just don't know how much. Sure. And one particular problem with that, and this is important, a lot of this is uneven between markets. So, there are some markets where, people are in a small local market without much competition in terms of providers, and because of the community rating requirements of the ACA, they're absolutely getting savaged with their premium increases.
I think I saw that they said it was Iowa, where they said it was one person that took something like $1 million a year in healthcare had basically caused just about every insurer to pull out and made it unstable. I think it's a KFF study I saw. Yeah.
Right, and again, the high risk pool approach is not perfect and will have substantial expenses as well. But it would basically say, look, we're going to take this cost, we're going to spread it among taxpayers generally, so that if someone is in a particularly bad local insurance market, they're not getting disproportionately affected. So, short answer, yes, it's going to cost a lot of money no matter what, but we still there's nothing we can do about that, and we just have to decide how we want to spread that out and among whom.
So if I was going to ask you and say we scrapped these three bills, we scrapped ACA, we scrapped the Senate bill, we scrapped the House bill, and we said we're going to start over here, what would you say is the best way to cover pre-existing conditions? If you could build a system to cover that from the ground up, what would be your plan to the best that you could describe it, I guess, off the top of your head?
Well, this may or may not be what you mean, but I actually have a different thought, which isn't really going from scratch, but assuming that we wanted to repeal the ACA and assuming we didn't want to do one of these two bills,
well, whatever you think is best. If you think one of them is the best way to do it, by all means, go that way.
Well, yeah, and I do have a lot of sympathy for the high risk pool approach being contained somewhere in these bills. Having said that, I do think there's room for another idea, and not everyone would agree with me on this, and you may not, but I think there's room for another idea here, which is that, remember, the Affordable Care Act was basically a big bet placed by the health insurance industry. I mean, basically, as you know, they bought into and supported the passage of the
Sure.
ACA. And the basic deal, it was kind of a no-lose proposition for them, which was that people would be compelled, mandated to buy their product or assessed a penalty if they didn't. If they participated in these exchanges around the country and made money from them, then great for them. If they didn't make money, there were various sort of reinsurance and risk corridor mechanisms
Sure.
set up to keep them from losing money. And if those didn't work, they could basically pull out altogether. So,
Sure.
so they basically made a bet with only upside, and they could pull out if there proved to be any downside. My own view is that it didn't work out, and there should be some mechanism for requiring them to take the downside of that bet. That you could grandfather in a lot of people with these pre-existing conditions in the plans that they had under the ACA, knowing full well that for insurers to continue those plans, they're going to have to operate them at a loss. And obviously that would have an adverse effect on the shareholders in these companies. And these aren't costs that would just be, magically born or would be invisible. But nevertheless, there does seem to me to be more, it would be appropriate to give more thought to whether some of these costs should be borne by the insurance companies who took on, these plans under the ACA, assuming that they could only gain money but not lose money.
Sure.
But now that we've got this problem and the exchanges didn't prove to be as stable as originally conceived of, why let them off the hook entirely? Why not require that these folks be grandfathered into the plans who already have them, knowing the insurance company is going to have to take the loss because of it, and thereby reduce some of the costs of covering these folks elsewhere in taxpayer-provided high-risk pools? It just seems to me that there's a lot of cost to be spread around here, and given the enormous potential windfall that insurance companies were willing to take on when the ACA was passed, it doesn't seem to me out of bounds to say that they should accept some of the costs going forward if the bet didn't work out.
So would you mandate that they offer policies in every state or every district, or is there some way to incentivize them? Basically say, if we want to say maybe take part in a group market in that state, you have to take place in the individual market, or is this more just kind of a...
Yeah, I'm not making a specific proposal
Sure.
here, and I certainly would not mandate the offering of any new policies. But I think for someone who is already on a plan,
So if they
in the same way that we're
if they like their plan, they can keep it.
Exactly. It's codifying what was promised several years ago but not delivered. If you like your plan, you can keep it. Now, of course, that's going to subject insurers to losses. But there's already been this discussion of should we grandfather on the people who signed up for Medicaid under the elevated match rate under the ACA. And well, if they could be grandfathered on, why would we not grandfather on the people who with pre-existing conditions who signed up for plans on the exchanges? Now, I certainly would not mandate that that anyone offer anything in particular to cover this population going forward that they're not already providing. But there does seem to me to be a place in this discussion for saying, look, these folks signed up for these plans in good faith. They were offered coverage at these rates, and you offered it when you assumed that this was all going to be very profitable.
Sure.
So maybe you should have to continue providing for these folks, at least the ones specifically who you are already providing coverage under these plans.
Sure. And it's really not, you're really talking about a few million people at this point. It's not like we're talking about 200, 300 million people that are suffering from pre-existing conditions and have availed themselves of an Obamacare individual plan. So to be clear, it's not like we're talking about doing that, and anyone you said post that would not be able to avail themselves of this kind of guaranteed issue pre-existing condition.
Right. This would just be, if you like your plan, you could keep it the way, the way it was promised previously, but not implemented.
Dr. Blahous, very interesting. Appreciate you taking the time with me today.
Thanks for having me on.
Separated.
Our second guest is former Cleveland Mayor, U.S. Congressman, and Democratic presidential candidate Dennis Kucinich. Thanks for joining us here on Debating Health, Congressman.
It's good to join you. Thank you.
Thanks. So just want to talk to you about pre-existing conditions and why we need those, in your opinion, in a healthcare bill. How do you define pre-existing conditions, and how do you see them fitting into a healthcare bill?
Well, they kind of define themselves. When people have a long-term illness and they don't have insurance, they try to get insurance, and in the past, insurance companies would say, well, you've been sick a while, and I really don't want to cover you. And in a just society, everyone would be covered, regardless of whether they've been ill in the past or not. And so that's the whole idea of having a caring society.
And what would be the effects of not covering people with pre-existing conditions?
People would go broke because they couldn't pay their bills. People would not get the care they needed in order to maintain their health. The quality of life would deteriorate. Family members would have more pressure put on them to be able to help loved ones who are ill. It creates a society of the survival of the fittest, and that's not a society that we should wish for. Pre-existing conditions are there for a number of reasons, some of which are the result of people's own bad health habits,
Sure.
and others which people have no ability to control, and it's not their fault.
So I'm glad you mentioned that. Should that have any effect? And I'd say this, I'm the type 2 diabetic, I found out last year, and a lot of that probably had to do with my lifestyle decisions. Should an insurance company look at me the same way as someone else you mentioned that may have been born with, say, a heart defect or some congenital illness? And should that affect my ability to get insurance, where I probably was a contributor towards my own issues versus someone that was not?
I think that we need a healthcare system that covers everyone. And at the same time, those people who have not made good decisions, we need health education as a continuing matter in our society to help people reach better decisions about what they can do to maintain and protect their health. I don't believe in punishing people for bad decisions they make, but society gets punished. That's true. But just think if we took a different approach, and from an early age, educated people so they could make healthy choices and choices that would be consistent with not just a longer life in terms of duration, but a better quality of life. So I don't believe that a healthcare system should be set up to punish people. It should be set up to make sure that people's bills can be paid. Now, if somebody, for example, wants a transplant, let's say a lung transplant, which is an extraordinary process, and they refuse to quit smoking, I think then they may not be at the top of the list.
Yeah, that's more of a scarcity issue than a pricing issue, I guess, in that sense.
Right.
But getting back to that pricing issues, I know we talked about how it affects society, but if we have community rating, for example, and everyone is paying more because of my poor decisions. Is that really fair to those people as well? People who did take care of themselves or people who did insure themselves before they got sick versus someone like myself or someone like you said who may have been smoking and been contributing without insurance and then had done damage to themselves and then got significant.
Well, the very nature of insurance is it's a pooling of risks. And some people have no risk and some people have high risk. My rates that I pay, I may not have needed serious medical attention for years.
Sure.
But I'm paying in case I do. And those who have needed it and who have used it fully, good for them if it keeps them alive. I mean, it's all it'll be about. We need a society that's all for one and one for all, and not one that just looks anxiously at his neighbor to say, "Are you going to cost me my meal or my health?" If we cover everyone with a universal single-payer care bill, and I wrote the bill with John Conyers in 2002. We introduced it in 2003 to cover everyone, and the country has the money to do it. I mean, $1 out of every $3 in healthcare goes to the activities of the for-profit system for advertising, marketing, the cost of paperwork, for executive salaries. And, we ought to focus on healthcare and not just a business of insurance. And so we need to make sure people can pay their bills when they need it. No one should go bankrupt. No one should lose their home. No one should lose what they worked for a lifetime because there's an illness in the family. We've got to be smarter about the way that we treat our country, and we certainly have the resources to do it. And it's not as though America cannot take care of its own. If it is our determination to do so.
But Congressman, I'm not sympathetic. Obviously, like I said, I have my own personal issues with this, and if I was on an individual market rather than my wife's plan under the old system, I probably would not be able to get coverage because of my illness. So I certainly sympathize with this. What I'm trying to figure out is, are we conflating health insurance with too many different things? I mean, I know you said a bunch of different things that people shouldn't be able to go bankrupt for an illness, but if I was in, say, a car accident or something, and I was a manual laborer, my injury may not be that expensive to me, but what may be that expensive to me is not being able to do my work. So at that point, whether I have health insurance or not, it's not the injury itself that may be the debilitating thing. It may be the fact that due to an injury, due to an illness, I can't work and make an income, where insurance probably wouldn't be a big factor in that. I know, some cases, cancer, some of these more expensive treatments, it would, but, if I have some kind of physical job and I break a leg or I get some kind of, mono, I might not be able to do a job. And even though the treatment may not be that expensive, that may still lead to those bankruptcies.
Well, look, we're talking about a number of different systems here. One is, when people get hurt, should they have access to immediate health care to save their life? Of course. I mean, there's laws to ensure that.
Sure.
And there's hospitals are required to treat. The second thing is, what about people with chronic illnesses? Should they be able to get care? Of course. Now, people are employed and they can't, and they're ill and they can't work. We really need to have a society which enables people to be able to go back to work and to not worry about whether there's going to be a job for them just because they've been ill for a while. This really is describing what kind of a society do we want. If we have a society where you get sick or you get in an accident and you're done, you're broke, you don't have a job, and you're not going to get help to recover from your injury. What does that say about who we are as a people? We can't do that. It's inhumane. And our country can be more humane. Our country can endeavor to care about people. Our country can make sure that people don't have to worry about being ill, people don't have to worry about whether they can afford, whether they're going to have a job, that they don't have to worry about whether they're going to have a roof over their head or be able to go to college or send their kids to college. I mean, there are fundamentals in a democratic society that we've been missing for quite a while. And one of the great reasons, this is not tangential to this discussion, is America's dedication to war making around the world. If we don't stop doing this, we're going to destroy our nation. And we're going to destroy the hopes that people have for a good future for themselves and their families. That's why focusing on health care is extremely important, and making less about health insurance and more about health assurance.
Do you think that is kind of where we've went wrong in this area, where, again, we've kind of conflated health insurance as a key to everything like that, rather than what you were talking about before in health education, health assurance, making sure people are healthier, versus just getting into the weeds on calling health insurance and acting like it's a magic bullet to fix everything?
Yeah, it isn't a magic bullet. And, it's a mixing of metaphors I prefer not to use, but there is no magic solution. There's a very practical solution. We want to assure people have their health through health education, starting from the earliest age, through giving people more options with diet and nutrition, through enabling people to understand that they can take control of their health with alternative and complementary medical choices, to be able to make healthcare more accessible to people in rural areas. I mean, there's all kinds of things we can do to start to lower the cost. And the fact is, look, the government can't give anybody health. We've got to do that for ourselves. We have to take responsibility for our own health.
Absolutely.
I mean, I know about this because when I was a young person, I had a horrible case of Crohn's disease, which later in life I was able to actually overcome against the odds because of changes in my diet. And so I can tell you that it is possible to take a new direction, no matter what kind of a health situation you're stuck with, as long as, unless you're talking about some kind of a condition that is a lifelong chronic illness for which there is no cure. But
there's usually things you can do to mitigate and improve. Almost no.
That's exactly right.
That's
exactly right.
How would you go about that? I mean, I know, like I said, we're talking about a whole bunch of issues and we've kind of moved beyond the scope, but they're all so related. So to do that, what do you think the best mechanism is? And I know if you were in charge of making a better healthcare system for the United States.
Yeah. Number one, don't pit people against each other. Number two, call on our commonalities as Americans. Number three, look at the common interest we have in a healthy society. Number four, teaching children what they can do to watch their health. Number five, making sure that children have access to good food, if not at home, at school. Number six, having jobs so that people can be able to afford good food, which is actually connected directly to whether or not people have health problems. Number seven, growing organics, because right now the food that we have is heavily laced with chemicals and in some cases antibiotics. And, we've got to take a different approach in terms of the way we grow food, in terms of what we put in food. We can change the attitude of people about health. Health is something that we can actually have some control over.
Who should be doing that? Should that be the federal government? Should that be state level, county level? Should that be private companies doing that? Should that just be individuals empowering themselves?
Well, there needs to be leadership that calls upon the innate capacity that each one of us has to be able to transform our lives and to take a new direction with our own health. I mean, I've had my own journey where I've had to discover what I could do to make sure that I wasn't going to be in a debilitating condition with a disease that in some cases claims people's lives. And I determined that I was going to take a different direction with a new diet, a vegan diet, with the use of Chinese medicine to improve my health. And I happen to be in the best shape I've ever been in my life as a result of making those choices. And the quality of my life is better, and the quantity of my life is better. And so each person needs to be assisted on their own journey without ordering them, but more with a compassionate approach that gives people a chance to explore health as part of the great mystery and journey of life.
So if you were looking at the federal government's role in basically making sure people, no matter the level of illness, no matter whether they were insured or not, to make sure that they were taken care of, what do you think the best way to go about that?
We need a universal single-payer, not-for-profit healthcare system. That's number one. We need jobs for all, education for all, retirement security. Those are fundamentals. And, these are things that are doable, but we got to change the direction of America. We have to change the direction of America to start focusing on things here at home. Our adventures abroad are starting to not just become distractions, but are putting us on the eve of destruction. And we really need to go back to that prayer that Lincoln had at Gettysburg of having a government of the people, by the people, and for the people. And that means you address people's practical aspirations for jobs, for good health, for a roof over their head, for education for their children, for retirement security, and for peace. These are all things that are achievable. They're not beyond our reach, and it really is time that in this moment of chaos we're experiencing in our country and the world, for us to try to go back to the purpose of nationhood, which really is about we the people and about the essential needs of what every individual has in order to participate in that grand experiment of creating a more perfect union. I really appreciate being on your show.
Thank you so much for taking the time.
Thank you.
So there you have it, listeners. Did you agree with Dr. Blahous about how we should find a different way to take care of our sick? Or did you agree with Congressman Kucinich that taking care of everyone at an affordable cost is how we need to handle healthcare in our country? Let me know your thoughts. Some other people gave me their thoughts on our discussion on one of our previous shows, should we legalize marijuana? Kamel Balach on Facebook said, experts debate? By whose standards are the debates experts? People have already voiced their opinions in Colorado, Massachusetts, Washington State, D.C., and Alaska. It's the people who decide a real democracy, not experts. Ethan Olson from Washington State said, Washington State now has $300 million in tax revenue to pay for schools and attic programs. It 100% needs to be around our lives. I suffer from ADHD, and it helps me like no other prescription I've had for it. I constantly get bored with things in life, and it helps keep me mentally stabilized. Otherwise, I'd be pacing the house like a caged tiger. Terry Gray says, you want to stop crime dead in its tracks? Legalize all of it. I heard a quote in college which basically said, if you don't remember the past, you are going to repeat it in the future. We act like we didn't learn a thing during Prohibition. All we're doing is creating more Al Capones to exist. Look, people are going to do what they want, regardless of the warnings you give. Example, tobacco companies tell you you're going to die if you keep smoking, yet people still smoke. So you can also comment on some of our previous shows, the ones we've done so far on steroid use, still on marijuana usage, single-payer healthcare, or this one on pre-existing conditions by contacting me at Twitter, @DebatingHealth, liking and commenting on Debating Health on Facebook, checking out our website, www.debatinghealth.com, or emailing me, Scott, @EhrlichHealth. That's Scott @EHRLICH health.com. I look forward to hearing your comments, and we'll make sure we respond to a few as we come in. And remember, healthcare is complicated, so the best thing you can do is educate yourself, do your own research, learn the issues, and take control of your own healthcare. Till next time, I'm Scott Ehrlich for Debating Health.
Dr.